So I'm going to thank Roger Hertog, the Hertog Foundation, for supporting this program. This is a research program. It's one that brings students from all across the country and some of them from abroad, from a whole range of different disciplines, to come together in New York and do collaborative historical research. Research that's historical in nature, but it's also meant to address emerging and future problems. This summer it's on global health and pandemic threats. Last year we worked on nuclear proliferation. And in coming years we'll be looking at religious violence, apocalyptic movements, and also climate change and international security. So that's the Hertog program, and thank you, Roger Hertog, for making that possible. Thank you, too, this summer to the Center for the History and Ethics of Public Health at the Mailman School for co-sponsoring this lecture series, and the Communication Department at the Mailman School for making available these refreshments. So thank you all. But more importantly, let me thank Donald Henderson. He is a distinguished scholar at the Center for Biosecurity of the University of Pittsburgh Medical Center. He was also a founder of that center. They're bringing more chairs. Fascinating, isn't it? So, yeah. So let me just mention a few things about D.A. Henderson. My colleague, my co-teacher, Steve Morse, introduced him earlier today to our students in the program. And he said, and it's true, how do you introduce somebody who led the worldwide campaign to eradicate one of the world's greatest killers, smallpox? It's very hard. But let me just point out how he's had already 3 careers, at least. First of all, he started out as the chief of the surveillance section of the epidemiology branch of the Centers for Disease Control. He went on from there at the age of 38. To head up the WHO program that succeeded after some 10 years in eradicating smallpox all over the world. He went on to be Dean of the Faculty at the Johns Hopkins School of Public Health. I won't say anything more about the Johns Hopkins School since I know we have a number of people here from the Mailman School, but needless to say, it gives us very great and very serious competition. And so from there, he went on and had a whole nother career in helping this country and the world prepare for the threat of bioterrorism. He helped to lead, not just in the founding of the center, first at Johns Hopkins and then at with the University of Pittsburgh, but then he went on from there for a number of important positions in Washington, ending with his directorship of the Office of Public Health Emergency Preparedness when that office was first created, and quickly had a $3 billion budget to deal with, where just a few years earlier he'd had trouble scraping together foundation support for the center in Baltimore. And then finally as the Principal Science Advisor in the Office of the Secretary of the Department of Health and Human Services. But he's come to us tonight to talk about smallpox, the death of a disease. I should mention he may be himself shy in mentioning the fact that it, I think, comes out of a really tremendous book with the same title. I found the book fascinating. I'm sure many of you will as well. And I think as memoirs go, especially by somebody who had already such an amazing career, 3 different careers, it's remarkably insightful and open, I think, in acknowledging the great ironies, in some cases tragic ironies, of the many careers that he's had. The one thing that we all know him for, of course, is in eradicating smallpox for all of us, but then to later in his career have to once again confront this terrible scourge, at least as the potential of reemerging as a terrible scourge in the form of bioterrorism. It really is an epic story, and so he tells it incredibly well in that book. But he's going to tell us tonight about some aspects of it in his lecture. So I want to thank him again for coming, and thank you all for attending. Thank you.
Let me say it's a great pleasure for me to be here, and with the Mailman School of Public Health has been a particular interest of mine, because Alan Rosenberg was a very dear friend and somebody whom I had an enormous respect for. And as deans at schools of public health, they get together, I guess, what they talk about, all the problems they have. And it sounds like Hopkins and Mailman School of Public Health have both opportunities and problems that are very similar, and a real challenge in public health at this point. But let me say, too, I'm especially glad to be here with Steve Morse, we've been together off and on early days when somehow or other the threat of a bioterrorism was not taken very seriously by many people, and also the new and emerging infections idea that we had a threat potential from agents coming into the country, and really that it was something to be taken seriously, and we really ought to be working with other countries and other laboratories far more closely than we are, and we ought to be learning a good deal more about and doing research on a lot of the diseases which many regard as exotic diseases. But we must remember AIDS came in '82, and where is it today? This is just one of many diseases that are have become part of the world scene rather than isolated in some remote area. But today to talk about smallpox, which I'm sure none of you have seen a case, and I think I encounter many people, they think of it as, well, I guess it was one of those diseases with a rash and probably occurred in the tropics, and I don't know. In fact, many people add, I suppose there's a little bit still left somewhere, I don't know. But it really passed from recognition because the last case occurred 34 years ago, and it's understandable that that this seems like something that's ancient history. To many of us, though, it is still very much contemporary history. And it was 1980 that the World Health Assembly met, reviewed all the material and the report of a special committee, and declared that the world and all its peoples have won freedom from smallpox, and recommended that vaccination be discontinued everywhere. It was a remarkable event. In the last year, we've had a number of celebrations culminating with a large statue outside of WHO of a vaccinator commemorating the last of smallpox. This was the way it was announced in the magazine of the World Health Organization, which seemed to get to the point very specifically. And to put this into perspective, from the Lasker Foundation is award to WHO, and as they say, smallpox, mankind's most feared and devastating infection, has frequently changed the course of history itself, and indeed it has again and again. Richard Preston, the author who's written several books, including Demon in the Freezer, called it that this may well have been the greatest life-saving achievement in the history of medicine. And finally, the Secretary of Health, Tommy Thompson, said that the campaign is a testament to the difference the global health community can make when it truly comes together for a common purpose. And it truly did. And in fact, through some of the darkest days of the Cold War, we were working very closely with the Russians, who were very helpful in many, many ways. But to put this into context of history, this is a disease which we know goes back as far as the pharaohs 3,500 years ago, because there are mummies, 4 to be exact, which have lesions. You can see them pretty evident on the under the neck, and they clearly died of smallpox, and so we have an indication that they go back at least 3,500 years. And throughout history, it has been a pestilence well beyond anything that you can imagine. It's certainly far worse than plague or any of the other diseases that you could mention. It has been a killer. It is the only disease which is represented by specific deities. And this is true, and there are deities in Japan, from Chinese literature in Japan, in China, in India, in West Africa. And it's the only disease for which there are specific deities, and in India, extensive numbers of Sitla Mata temples. And I think this is an indication that the peoples throughout the ages have regarded this as one of the great problems, as no other disease. But even until fairly recently, it was more of a problem than we might imagine. First of all, we go back, and in the 20th century, we conservatively estimate there were 300 million deaths due to smallpox. And the New York Times came up with a metric in comparison saying, do you know that there were 120 million people died either directly or indirectly as the cause of armed conflict in the 20th century? In other words, 120 million due to armed conflict, 300 million to smallpox. So this is a disease of great magnitude. When we began in 1967 with the Global Eradication Program, the closest we can come is that there were about 10 million cases and 2 million deaths that year. That year it was reported from 43 countries, and many people don't realize that we required vaccination in this country of all school children up until 1972. And that was 23 years after the last case in this country. So great was the fear of smallpox coming in, being introduced and spread, that we were continuing vaccination, as were other countries, continuing vaccination for a disease they did not have simply because of the fear of smallpox. So let me say a word about the disease itself. It's a virus. It spreads from only during the rash. Man is the only host, so there are no animal vectors on this, no animal infections. In fact, this has been a problem in research because we have no experimental animal that we can infect with smallpox. And as you think about it, this means that one individual has to infect another individual, has to keep another individual if it's going to keep going. So we pictured and talked about it as a chain of infection that had to keep going constantly. If you could break the chain, you obviously prevented many cases. So the death rate for smallpox runs about 30%. The cases, there are no subclinical cases. That is to say, if somebody's infected with the virus, we have a rash. And so it's very different from many other diseases where there are subclinical cases. But for those who survive, they're permanently immune for life, so that one attack is all that anybody will have. So with this disease, we had something which was really quite unique and very essential, and that is we had a vaccine developed originally in 1796 by an English country physician named Edward Jenner, who discovered, as the lore of the time, was that milkmaids did not develop smallpox. In milkmaids, they praised their complexion. If you remember from many of the stories, they praised the complexion of the milkmaids. It wasn't because they were drinking milk. It was because they had cowpox. They were prevented from getting smallpox, and so many of the women of the period were scarred, seriously scarred, with smallpox. And that it was a real problem. So here's this disease, the vaccine, which has been done first in 1796, and there's been vaccination going through history all the way up until the present, using a strain of cowpox, which is a cousin of smallpox. It's not derived from smallpox, it's a totally separate virus. Now let's just take a look at a case. That doesn't show up very well because of the light, but that's all right. You can see here, there are just, you can see they're just small papules, small even vesicles on this child. It's a Pakistani boy who recovered from this. But what he would have had would have been 2 days of very high fever, really miserable. Many children had febrile convulsions with this. And then this would be the 3rd day of this rash, which is now developing. We'll go on and we'll see the rash. The vesicles are becoming pustular, pustular rash. And we feel at this time it would take an individual about the 5th day that if you saw it in the emergency room, you wouldn't see, you saw this child, you would say it could be any of a number of different diseases. But if you saw this, you would certainly have second thoughts about this. Is this smallpox? So that's day 5. You can see he's miserable, and he has the lesions are on inside of his mouth and on the tongue. So he has trouble drinking, he has trouble eating. It's really a very bad disease. This is day 7 as the pustules grow. Day 9, you can see it going on, and then day 13, scabs are now forming over the pustules. The pustules are just not being scraped off, but they're just resorbing. And as you can see, he looks a good deal happier than he did at the earlier days. Now, he recovered. This is what we'd call a little more severe case. This is an English engineer who came back got infected in Pakistan, came back and developed the smallpox. And you can see these round lesions that are on the chest. And this is the man, that's the same man on recovery. And you can see, when they talk about scarring, you can see how prominent this is. Now, with the scarring also came cases in quite a number of cases of blindness. So in fact, this was a leading cause of blindness in India up until 1975, and similarly in Europe in the 18th and 19th century. So what is eradication, and why at this time? Well, we can go back, and there were several efforts at eradication. The first was hookworm, which was funded by the Rockefeller Mr. Rockefeller before the foundation. And the idea was to treat patients with the disease and provide pit privies and encourage that shoes be worn. And after some 14 years, they went back to see what they'd been accomplishing, and they found that there was less infection, but it was still continuing to spread. You couldn't stop it. Yellow fever followed in 1915, and the discovery that you could simply control mosquitoes, Aedes aegypti mosquitoes, which will transmit it. If you could control it in the major population centers, that it would die out in the periphery, because mosquito is very much lives very close to man. They began that, and again it was Rockefeller sponsoring this, and they did quite well, and up until 1932, and then they discovered with most of Latin America was free of yellow fever. Then they discovered that there were cases occurring, and that there was a jungle yellow fever carried by monkeys, and that it could come back to man, and so that was the end of that one. Malaria followed in 1955. DDT had been discovered during the war. It was a tremendously effective insecticide, and the idea was to spray the walls of a house. Mosquito bites the individual, becomes infected, flies to the wall to rest, and is killed by the DDT, so the mosquito does not spread it. And this was very effective in a number of areas, but it soon became apparent, one, that the insecticide was becoming resistant, the mosquito was becoming resistant, and the parasite was becoming resistant to some of the drugs, and it was a lot more expensive than they'd ever imagined. And so after $2 billion was expended, and when you say $2 billion, that's when $2 billion was really serious money. And at that point, it began to fade, and 1973, it finally came to a halt. Well, 1967, the smallpox got underway, and that was a decision of the World Health Assembly to begin this program. And you can see it was at the time malaria eradication was failing, and so there was a lot of concern about going ahead with smallpox eradication. I'll can say a little more about it. Later, guinea worm infection, the worms that you see pictures in the National Geographic of worms coming out and people wrapping them up on a stick, that's the guinea worm. And it's tropical Africa now only. But they began an eradication program in 66 or 86, and it's now 24 years. It was supposed to be over, hopefully, in 14 years, and it's still going. And unfortunately, most of this is in southern Sudan, where all the fighting is now beginning and breaking out. That's been a real problem. And then polio, which now is in its 23rd year, and where there's still polio in 4 endemic countries, and about 3 others are seriously reinfected. About $1 billion per year is now being expended just on polio eradication. And there is hope now that Gates Foundation's got very much involved, and hope that by the end of 2012 that the last cases will occur. But there have been disappointments again and again and again, so I won't go into that, but it's polio is still with us. So those are the 7 eradication programs. The way smallpox came about was in 1959, the Soviet Union had come back to the United Nations. They'd withdrawn all representation in the UN because of the Korean War that was going on. Are we right on the Korean War? Yes. And so they'd withdrawn, and for nearly a decade they were out. They just came back, and the delegates wanted to be supportive and say, fine, let's all get together, and we agree. And so began a program in 1959, which was not done very seriously. And there was a budget of $100,000 per year, and they had a staff of 5 people, and you can imagine not a lot was getting accomplished. And there were only 5 staff members at that time. So the Soviet Union was really very unhappy about this. The U.S. was supporting malaria eradication, putting a lot of money into it. The Soviets over here were supporting smallpox smallpox eradication, and they were providing a lot in the way of vaccine and trying to do things. But every year they were saying to the Director General and to the Assembly, we really must do more. Why are you playing favorites? And with the Americans and the malaria program, you should be supporting more the Soviet-sponsored, Soviet-supported smallpox program. So at this point, the Director General was very frustrated. WHO did not have a lot of money, and he decided that they would put together a program, a plan, 10-year plan. And this Director General planned to support to introduce it to the Assembly and then see what they would do, and he was confident that they would vote it down because it cost a lot more money. And the plan, the strategy was unique. At that time, there were a number of smallpox programs going on where people trying to vaccinate quite a few, because it was such a problem disease that most countries had to have some sort of a program. And the goals that were set was to vaccinate 80% of the population. And the key thing that was unique was the second component of it was to say we should have a beginning, at the beginning of the program, we want a report from every health center as whether they got smallpox or they don't, and made provision then for teams to go out and try to stop the outbreaks while they went ahead with a routine vaccination, try to find the cases, stop the outbreaks. And this was important because the question was, where is smallpox? Where are the real problem areas? Who was getting the disease? It's just made sense to be studying a disease to find out its epidemiological characteristics so that you can tailor your program. And a number of things came from that which were surprises to us. One, we found out it didn't spread half as fast as everybody said it did. They said it spread like wildfire. Well, it didn't spread all that fast because you remember it only spreads person to person, and the individuals usually got so sick at the end of the second day, by the time the rash begins, they're in bed, and it spreads to contacts immediately, but you don't have people in schools, you don't have people in workplaces, but it didn't spread rapidly. And I can go on. There were a number of things that we found as we went into the surveillance program. But those were the two components of the program, the two major pieces. The Director General felt that WHO could or should support this to the extent of $2.4 million a year. Well, that sounds like not very much, and in fact, it really wasn't all that very much, to tell you the truth. But their whole budget was only about $55 million at that time. So $2.4 million on top of this was going to be quite an expenditure. The delegates objected. There are a number of people said, we've tried to eradicate malaria and it can't be done. So why do you think you can do this? We can't have another failure. And many of them, including the U.S. and major donors, said, contributors to the World Health Organization, said we don't want to spend more money in the international organizations, and that was a philosophy at that time. And the WHO's budget is made up of a certain amount of money that every country has to contribute a certain amount, and it's based on their GDP, and so that the U.S. paid, at that time, was paying between 25 and 30% of the budget, as I recall. And so the big donors said, we don't want to put more money into this. And so that was a group that was objecting. The Director General was opposed to it because he didn't think it could be done, and he certainly didn't want another, as he saw it, another albatross around his neck. He's already got the malaria bit. So he was opposed to it. But they took a vote, and it had to have 58 votes to approve, and 60 voted for it. So it barely made it. It was within 2 votes of not going ahead. So he blamed the U.S. as having been supportive, as they hadn't been before. They'd been mainly focusing on malaria, but on this occasion they did join in saying we really ought to get rid of smallpox. They voted against the budget, by the way, later on, but that's another story. But the Director General felt it was the U.S. that was getting WHO into this terrible position. So he wanted an American there, and quite candidly. So when it goes down the tube, fails, the U.S. will be seen to be holding the bag on this, along with WHO, and it will not blame WHO so much. So I was working in the Centers for Disease Control, working in the smallpox area. I had a number of diseases that we had under surveillance, and I was chief of the surveillance section at that time. And one of them was smallpox, and it was for good reason at the time. We were doing some studies. So he decided he wanted me as director of the program, and I got called to the Office of the Surgeon General. And he said, you're going to go to Geneva as head of the program. And I said, well, I'm Public Health Service, and we don't do this in the Public Health Service. It's not like the Army, Navy, Air Force, they, assign people and they move them around. Public Health Service, we discuss it with career options and future and so forth. His answer was, this is your career option. And I said, but suppose I decline? And he said, you resign. And I got the impression he was serious. So at that point, I picked up and went off to Geneva for 18 months. So the agreement was it would only be for 18 months, and that if I sent a cable back, just to say now, he would extricate me and have me brought back. So with 3 kids and a wife, we left half of our household goods in storage, expecting we'd see them very shortly. And it was 11 years later that we unpacked, and you can't imagine what was in that. Well, the reasons to be concerned, because you look at, we felt we had to have programs in at least 50 countries. And you add it up, and you've got $2.5 million. It's $50,000 per country. But it wasn't enough to buy the vaccine. We could not buy the vaccine with the amount of money that was being appropriated from WHO. There was hope that others would donate, but the record of their contributions from the industrialized countries and others, voluntary contributions, was very poor. It provided for headquarters staff, which was 10 people, 4 medical officers, actually 5 medical officers, 2 administrative officers, and 3 secretaries. And that was the total staff we ever had. The whole staff never got to be larger than 10. And this was a time when you didn't have the internet, we didn't have Twitter, we didn't have Facebook, we couldn't even use telex, it was too expensive. You couldn't telephone to most of these places because even the communication to the capital cities was terrible. So mostly what you had to do was basically this was travel and by mail. And this is it was a challenge, let's just put it that way. We also had the problem that every country is sovereign. So they can decide whether they really want to participate or not. Never mind what they voted in the World Health Assembly. They could very jolly well do it or not do it. And we had some countries that decided they weren't interested in going ahead with it. So we had that as a problem. And WHO actually has 6 regional offices. Each regional officer, chief of each regional office, is selected by the countries of that region. And it just really does not function very well as a WHO. And in fact, the Director General, Dr. Hopkins Mahler, said to me, what we really have is an association of regional offices, so that of these 4 regions that we had to work, we really had lukewarm support for 1, and total objections by 2, and 1 who would go along. So we had from the regional offices very little help, and I really was not too inspired to think we were going to be getting very far. It was really looked like a hill. Fortunately, the problems appeared and kind of one by one, and we'd solve a problem and then another big one would come. If I'd known at the beginning, or we had all known about all that we would encounter, I'm not sure we would have had the courage to go on, but just one by one, they got sorted out. 1967, this was the situation. The red countries are those where it was endemic, that is constantly spreading. The blue countries were those which were thought to be free and were having smallpox introduced. Now in Latin America, you see that Brazil is infected, but only Argentina had some importations. Now, what had happened was that there was a vaccine, a method to produce a smallpox vaccine called freeze drying on a commercial scale, which had been developed in the UK in the late 1950s. And they'd introduced it for a couple of countries. And in the Americas, they had several laboratories using this freeze-dried vaccine. Well, it made a difference because this vaccine could be kept at 98 degrees Fahrenheit, 37 degrees centigrade for a month, and it was potent at the end of that time. So little problems with vaccinators going into the field. Whereas the old vaccine, a liquid preparation, it was 2 to 3 days is all you had, and then the vaccine was no good. Well, that had been introduced a bit into Latin America, and that was being more effective than anybody believed or realized at the time, because the reporting was so bad, we really didn't have a very good idea till the 2nd or 3rd year, really what was going on. Africa, south of the Sahara, actually all of those countries were really infected. We just didn't know it at the time. And then you have the India, Pakistan, Bangladesh group, and then the islands off to the right, which are Indonesia. The real problem was, how do we get enough of this vaccine? And so we decided to do something which we were told we couldn't do. We had to have some quality control. Now, each of these countries making their own vaccine. I think we had something like 74 different laboratories making vaccine. You can imagine what some of this was. So we decided on our own that we would just not offer WHO assistance to any country that was not had a vaccine that would not meet international standards. So we weren't saying what your standards, what your vaccine should be or had to be, but we weren't going to provide support if you didn't have good vaccine. And it was amazingly effective, even though this was something that we were told WHO does not monitor and license vaccines. That was for sure. Well, we weren't. But we were just making sure we had good vaccine in the field. So we managed to, 2 countries, Canada and Netherlands, offered to test the vaccines that were there. And so we got the vaccines were being sent in, and we found that less than 10% of the vaccines met any international standards. So most of these people were vaccinating, some of them were vaccinating with no more than water, but they were still putting it into vials and sending it around. So we had to develop a national capacity. And what we did was bring together the heads of laboratories from 5 different countries, sat them down for 2 weeks, and worked out a manual, which was simple enough, we said, so that I could understand it and could make vaccine. And they did this, a very good manual, and then they went out from the different laboratories, one Soviet Union, Netherlands, US, Canada, and Britain. And they were the directors of those labs, went to developing countries labs, works with them to get them started, and worked. And eventually, by 6 years, we had more than 80% of the vaccine was produced in the developing countries. So our target for coverage was 80%. And here again, we had what we felt was important was to get quality control. And this was something we had a very difficult time persuading ministers of health that this was a good idea. And the idea we had was simply to have a team or teams that would go after the vaccinators had gone through. And when you vaccinate, you're putting a little drop of vaccine here, you're scratching through it or putting it in. I'll talk about that. Then you get a pustule that comes up and a scab, and then it falls off. So you've got evidence of vaccination. So a team coming through a week, 2 weeks later could see who really got vaccinated. And so the idea of having a team that did nothing, no vaccinating, but simply was checking on the work of others, was objected to, I would say, just about by every ministry we encountered. Why aren't these people vaccinating and not just checking on what somebody else is doing? But this made a huge difference. Then it was tried to find a faster, better method for injection, and we tried the jet injector gun. I won't go into that, but it worked very well when it worked. You could vaccinate 1,000 people an hour, but the trouble was it broke down so often that it just wouldn't, we had to give it up. The great invention was the bifurcated needle. And this was regarded as a tremendous breakthrough. It was a big enough breakthrough so that the City of Philadelphia gives a prize every year for the outstanding invention of the year, and they've done this since 17 something or other. So it's Marconi and Edison and so forth and so on have been awarded this. And the man who developed the bifurcated needle received the James Scott Prize. And he said, this is the least important thing I ever invented. Well, I'll show you what he did. That's the needle. It's so long, and all it is got 2 points on it. And the idea that he had was that you've got vaccine, and it's a liquid, and you dip it in, and just enough virus is held their vaccine for vaccinating. And at the time, the U.S. was doing vaccination sort of by pressing the vaccine into the skin. But you were taught very carefully not to break the skin, not to get blood because it would wash the virus out. So people were being very careful and not getting it implanted in the skin. So we had many failures. So we decided, well, let's take the needle and suppose we do this and just have them do a number, what we call multiple punctures. And it's very sharp and very, very painless, really, when you do that very quickly. And we got effectively 100% coverage of takes. They were just, every vaccination was working. So it had a huge effect because the amount of vaccine required was only a quarter as much as what we'd had with the other ones. The training time was 15 minutes for a villager. You could sterilize it, put it in a bucket, boil it, be ready for the next day. And it cost us $5 per 1,000. It was suitable for our budget. So this was the surveillance plan, which I already talked about. And we were finding that about the disease spreading like wildfire. And there's also the feeling you had to revaccinate every 3 to 5 years. And we soon found that vaccination was probably good for at least 10 years and probably longer. So any plans to revaccinate, we scrapped them at that point. And that made a big difference. The women in Purda could not be vaccinated in Afghanistan. And we sat down with the village leaders and talked this over, and they agreed finally that the woman could be vaccinated on the back of the hand, and so they were accepting vaccination, and once they accepted it, they could accept it for the children. And we got very good coverage of smallpox vaccination in Afghanistan. In the management of the program, I thought there were a couple of things that are important, and I think they're important in the global health. That this is a program that had to be adapted to the country and what they were doing. In the malaria program, it was a rigid set of precepts to what to do, when to do it. This we adapted. The idea of all the staff being in the field 1/3 of the time, and that was for our headquarters staff too. So I spent more than actually 1/3 of the time, not just at the headquarters, but going into the field, talking with the vaccinators, getting an idea of what's really going through, what's getting through. And in the course of this, learning a very great deal. And we insisted on that for all the staff. And then sending out reports regularly, so every 2-3 weeks. Some places more often, we sent out reports, what's going on. Brazil started a program to put out a report weekly, and that is now their national infectious disease surveillance bulletin. It is true in a number of countries. This was kind of the beginning. And basically, I'd say the bit of red tape is inevitable, and people talk about it all the time. I was talking with some of you in the group, but there are a couple of things you learn. When you're not sure whether something should or shouldn't be done, it's the best thing to do is do it and ask the question later, not as a hypothetical. And then when you're finally found out and not a good thing to do, don't argue with them. We just learned that mea culpa, I'll never do it again. You probably only had to do it once to get it done, but that's all right. So that these are hints for the field that, as people learn, was very good. 67, that's just where we were. 69, there's one change, significant change. And that's in West Africa, this whole area. There's only the one red dot, which was Nigeria. And this was a program that we set up at CDC just before I left. AID decided to come forward to support a program in West Africa, 20 countries. And so we'd set it up, and we were just dumbfounded. Here we are 3 years later, and these countries are among the poorest in the world. Their smallpox rates were among the highest, and here we were 3 years later, we're virtually free. Well, you can imagine, we were elated. It was, we could see we didn't need 10 years to get this done. This is surveillance containment is going to make a big difference. By 1973, you can see all of South America is free, Indonesia is free. The only countries in Africa are Botswana, but those are the last few cases they had, Ethiopia, and just India, Pakistan, Bangladesh. So it looked like, you know, you're really moving along, and we're only 6 years into the program at this point. But that area of India, Pakistan, Bangladesh, you're really dealing with a population at that time of something around 700 million people. And that the program was not working. We really were not making progress, and we didn't really know what to do. And we found that people in India and the subcontinent really move around a lot more than we'd ever imagined or we'd encountered in Africa. There are roads, there are the jitney buses, which you can see here with quite a capacity to move people around. The whole families would move from place to place. So it was much more population movement, and we were running behind. We weren't getting the outbreaks fast enough before it was moving on. This is a train going north out of Calcutta. You can see the air-conditioned compartment on the top. And as we discovered, very few tickets were collected. And in fact, one that we did check on, there was just one ticket sold, and that was our WHO advisor who had bought the ticket. So it was really a lot of movement. So what did we do? With a population in India of 550 million, we decided in the spring of that year, in fact June of '73, that what we needed to do was try to search every village in India in 10 days' time. And we worked with the Indian government health department planning this. So the idea was to go to 4 different parts in the village and so many tea shops and to ask about cases and try to reach every village in 10 days. The first results came back, and one state of India, which was at that time, I think they were reporting 500 cases a week. Teams found 10,000 cases. And I must say, the reports came in to us in Geneva, and I thought, oh my God, 10,000 cases. This was October, and the smallpox season doesn't really get started until late October, November, when you really begin to get it spread. And things look pretty grim. But then the staff got organized on this and said, let's go to every house, not every village. And so they set up a program to visit every house in India in 10 days' time. And you say, yeah, I know, yeah, they went to all the houses. But we had quality control. And the quality control team went afterwards, and if they didn't get 90% of the houses, they had to go back and redo the whole search again. And so we had a pretty good idea that we were really getting cases, and they were beginning to get contained. Spring of '74, we thought, as January, February, I remember discussing it at the time, we felt this is the worst, this is India. If we can defeat smallpox in India, we're going to be able to do it the rest of the world. And we were really elated at that point. And then the roof fell in. There was, you remember, the petrol crisis in the Middle East, and they wouldn't ship gasoline. We couldn't get gasoline for the cars. And the railroads went on strike, and the airlines went on strike. Then the health staff was threatening to go on strike. And about this time, they had some of the worst floods in decades in the whole area where the smallpox was heaviest. And there were refugees by the thousands, tens of thousands, moving around with smallpox. And it really was, looked really grim. And then May, India exploded the nuclear device. We figured there isn't too much more that could happen. But this turned out to be the real breaking point, because there were a huge number of international staff, reporters, witnessing this event. And here in India are the headlines. nuclear device being detonated, and smallpox in India at its highest level in 20 years, 2/3 or whatever it was of all cases in the world are in India. And this did not go well with the Prime Minister. Mrs. Gandhi was very unhappy, and we got a lot of help suddenly from India, the authorities, and that really was really the pivotal challenge. At that time, we began to focus on, we're not doing vaccination. We don't care how many vaccinations we have. What we're really looking at are cases, so that the target is zero cases. And it's strange as it may be, I wound up at a dinner sitting next to a man by the name of Charlie Schultz. And what do you say to Charlie Schultz? I didn't really, make conversation. And I said, I'll bet Snoopy hasn't been vaccinated. With this, he grabbed a sheet of paper off there and started sketching madly. And he handed it to me, smallpox target zero. But he says, he wants you to know he's behind you. So that's the story of Snoopy and smallpox target zero. On Indian Independence Day, the Prime Minister announced, saluted India on its 28th anniversary of freedom. And this is the big event, the major holiday in India is the Independence Day on August 15th. And she makes a speech from the Red Fort. And I would say it was at this moment that, to me, was one of the great touching moments, something that really I'm still emotional about. When she announced that India was free from smallpox for the first time in written history. At that point, I really began to see something of the meaning here, which I just had not grasped before. It was a very moving time for all of us. That left us only Ethiopia. It's a country twice the size of Texas, so it's not as small as it may look. It's quite large. Largely highland. The health facilities was at that time serving about 5% of the population. And travel by the staff was largely by donkey and on foot. You could only go so far and drop people off, and they would head off across country and be picked up a week or two later, hunting for cases and vaccinating. Well, at 1974, as India is getting free, the Emperor Haile Selassie was assassinated. There was a Marxist takeover. Virtually all of the foreign people from the embassies were evacuated. There were 3 different civil wars broke out. And there were really no foreign staff were allowed outside of Addis Ababa, the capital, by the government, except for our smallpox people. And they kept going through this. They wound up we had 9 different occasions. We had the team kidnapped, and they'd turn up 8, 10, 12 days later. They were being picked up by Somali guerrillas and taken into Mogadishu. We had 2 helicopters that were leased for us by the U.S., and we were using those to get people around. They captured a helicopter, and we had a ransom note to free up the helicopter. While they were negotiating this, the pilot, Canadian pilot, was doing this, and he vaccinated all the rebels. So when they picked them up, they were all vaccinated. So it finally came to an end. Somalia got infected. Just as Ethiopia was finishing up, we ran on more than 1,000 cases in Somalia. It was a desperate effort to finish up Somalia before the Hajj began and pilgrims began moving through Somalia into Mecca. But this was the last case at Ali Milan, at 26th of October, 1977. So we missed our 10-year time frame or goal, which still annoys me, because it's 9 months and 26 days over. And if the Somalis had not been so difficult in hiding cases, we would have made the 10-year goal, but we didn't. But that is not the end. and this is, let me summarize very briefly. What came from this was the launch of what some are now calling the beginning of the vaccine era. When we began with smallpox and trying to reach everybody in throughout the country in 1967, there was no vaccine and no country in the developing world that was trying to reach everybody in the country with a vaccine of any sort. So that in looking at equity and health services for all, this was the first effort to do this. What we were so surprised when we were working in Africa was that the African vaccinators were vaccinating an average 500 people a day, on average. So you had a team of 4. They were doing 2,000 vaccinations a day. And what this really was the result of was a pattern of working with village leaders and getting support and assistance and school teachers and what have you. And when we saw this, it seemed to me that we really ought to be doing more than that. Why aren't we giving DPT or measles or polio? These are being used in the industrialized countries. Why can't we do it there? So we, in 1970, convened a WHO meeting and brought this up, and it was discussed, and finally it was decided that they would recommend a massive program, well, let's say vaccinations, so that all children got at least smallpox, DPT, measles, polio. And so that was passed then in 1974 by the World Health Assembly as an objective, and became the expanded program on immunization, which I could kick myself today because we did this meeting and that was the goal. And we could have done something, war on disease or something, you know, or vaccine war against disease. But instead we got this sort of bland kind of thing. That's what's known as today, but EPI. So UNICEF took this up as a high priority. Rotary volunteered to raise $100 million for polio vaccine. They've since raised something around $700 million, I think. The target was 1990 to reach 80% coverage for children throughout the world, and substantially that was achieved. And it's gone on from there, and there are other programs in place. I just will show you this brief bit about the Americas, because the program actually got started in 1975, and by 1980, the coverage was running about 50% for DPT, measles, and polio. By 2000, they're up to 90% with those three. They've introduced hepatitis B and H influenza. And now we're running pretty close to 90% throughout the Americas. And these are all the countries in the Americas, with the exception of Haiti and Bolivia, which they've lagged, and that's been a problem. In the course of this, in 1985, the head of the chief advisor there, with WHO chief advisor, Ciro de Quadros, recommended that we undertake in the Americas to get rid of polio in 1985. And that was agreed with a 5-year goal set, and in 1991 the last case occurred. The Caribbean countries expressed they were very unhappy. Why were they unhappy? Well, they didn't have anything to eradicate because they didn't have polio. So they wanted to eradicate something. So they wanted to eradicate measles. Well, I was chairing the advisory committee at this time. I must say I wasn't too enthusiastic. There's a lot more problems with getting rid of measles than with smallpox, but never mind, it was supported. They went ahead and did it. The last case of endemic measles, or let's say continuing measles, except for importations, occurred in 2002. The next step, though, they were giving measles and rubella, the German measles vaccine, at the same time. It's a combined vaccine. So they decided, let's get rid of rubella, because it causes a lot of malformations. Mothers have the rubella. Well, this gives another problem, because rubella doesn't spread so rapidly, and it can keep going in an adult population. So they set out to vaccinate women up to age 40, and it didn't stop it. So then they decided to have to vaccinate men up to age 40 as well. And there's nothing more difficult than vaccinating adults. They just really are not very cooperative. But in 2008 was the last rubella case in the Americas, and the congenital rubella syndrome, which was such a problem, is no more. There are no more cases occurring. So this is an overview of the world. These are WHO numbers. The lower figure, the lower curve is the one to look at. This is polio beginning 1980. And they actually estimate there are about 350,000 cases, but there's some 50-odd thousand being reported at that time. And these are reported cases, and so now we're running around about 1,000 cases worldwide. You can look at measles, and this is what's happened in global measles coverage, and many people just don't realize what has happened. And there are many changes that have occurred, and you can see the numbers of cases here on measles are way down, and deaths are way off throughout most of the countries, with some very few exceptions, but that's getting more of a push. So I think there's some important lessons from all of this, and it's not what do we eradicate next, but to say that vaccines are clearly a very valuable intervention for health. And the World Bank study, which was done in the 1980s, said that this is the best cost-benefit medical intervention available. I think on our management side, this idea of having disease reports and doing this regularly is important. In polio, this was not pursued for 12 years after the global eradication began. And so it's begun after around 2000, really pushing to get reports in a way. You're trying to get responsibility, you're trying to get flexibility, you're trying to get health staff, the village elders, the field staff involved in a way that cannot be top down. You've really got to, it takes time, but you've got to build with the support and ideas that these people have, because there's often many different thoughts about how to proceed that can come in. And then it was amazing to see the way political differences disappeared with the U.S. and Russia working together. And we did very closely. So from the book, this is a sort of concluding bit to say that we are only beginning to realize the potential of public health. And it is a field begging for fresh, resourceful ideas and a new generation of professionals who are not constrained by knowing what can't be done. And that's the way so many of our people working in the field knew, and they were told that it couldn't be done. And so they didn't know they couldn't do it. And so it was with many who contributed so much to making eradication a possibility. Thank you.
So I think Dr. Henderson is willing to answer some questions. And what we would ask is that, is there a microphone for? No, okay. Well, try, if you could, in asking your question, if you could speak up, because we're recording this on the web, and some people are watching even now. So try to enunciate if you want to ask a question. So I see a few hands. Let me begin with Chelsea, and then I'm just going to work my way back. So there you are.
So this might be sort of a pet question, but you mention in the book that there are two types of smallpox. There's ordinary smallpox and then flat smallpox. of which almost no one survives. Did anyone survive that? And I don't know, I was just interested.
About variably around 5 to 10% of the people would begin bleeding during the first week, and there were no survivors. And then there was a flat smallpox in which they didn't have those little lesions. They were just like a skin over it, and if you touch the skin, actually it's separated from, and it was just a horrible thing. And so these people died. There was absolutely nothing you could do for them.
There were no survivors of flat smallpox?
No survivors of the flat smallpox either. It was a hideous disease, I could tell you, from going through a ward with smallpox. Oof, it's something.
Yeah.
Thank you very much for your presentation. I was wondering if you could share with us your opinion on the recent,
Just speak up if you could, yeah.
I was wondering if you could share with us your opinion on the recent World Health Assembly's vote on delaying the eradication of the smallpox reserves for another 3 years.
Well, there's a significant controversy that's been going on, and that is, at the end of during the smallpox program, toward the end, we asked countries that had smallpox specimens in their labs to send them to one of two collaborating laboratories, Moscow and Atlanta. And by 1980, they were down to 2 laboratories. And those are the only 2. Other countries signed a piece of paper that in 1980 that they had checked, and they had no less specimens in their laboratories. 1985, there was an expert committee on smallpox for WHO looking at a number of things. One of them was, should we destroy the remaining smallpox virus? Is there a chance that it could escape? Why not just destroy it? So over the next 10 years, actually, the committee met on every year, 2-year basis. One of the things we were concerned about was to preserve genetic information. And so a library of fragments of smallpox were created of different strains. Then the virus was sequenced, so you had a real definitive map of not one but several strains. Then the committee then wrote to principal international and national microbiological societies and said, this is under consideration about destroying the virus. And we had written reports from 5 of the major microbiological societies who said, we agree, the virus should be destroyed. In year 1990, yes, I'm trying to think here. It was Louis Sullivan in 1990. He was Secretary of Health and Human Services. He announced to the Assembly that the U.S. would destroy its stock of smallpox virus as soon as it was sequenced. That was accomplished 4 years later. That he talked with his Russian colleagues and they agreed. So in 1996, the committee we felt we were finished. 1995, we felt we were finished. We wrote up the report and sent it to the Director General. The U.S. looked at the report and decided they didn't want to see it destroyed. So it has been before the World Health Assembly. In 1996, it went to the World Health Assembly, and it was finally agreed, because of the U.S. and Soviet Union, now Russia, objecting, that they wanted to do more research. So they said, all right, take 3 more years, then 3 more years, and then 3 more years. There's a lot of anger in a lot of developing countries about why are we not destroying it? What is the U.S. and Russia up to anyway? Why do you want to keep it? So this has been argued very heatedly. It was a major discussion at the World Health Assembly this year and went on for several days. And they finally decided that they would defer further discussion for another 3 years. So this is where we are, and I think my own feeling is we ought to destroy the virus. There's no question we should destroy it. And there are all sorts of objections being raised, but then let me just leave it there. This is, as somebody said, it's not scientific, it's political now.
Yeah, we do have a microphone now, sir. If you wouldn't mind, could you come to the front just so others can hear your question?
In this day and age of AIDS, would the bifurcated needle technique still be used if smallpox is still around? Even though you can sterilize it, there could be cases where it wouldn't be properly sterilized. So then, would this be no longer a valid technique for smallpox treatment?
Well, I think at this point there's a feeling that one should never have an instrument, a needle, to be reused at all, no matter how you sterilize it. So that this has been the what has been the tenor of what we should be doing if we're putting up a stockpile. We should have a needle for every vaccination is going to be done. But the difference between this and an ordinary needle, you have a hollow bore. And trying to sterilize the needle thoroughly and make sure nothing is there is more difficult. Here you don't have the hollow bore, and the likelihood of transferring something is pretty minimal. So that I think from all the lab studies, there's really, one would not need to do it, but I think as a principle, the decision has been made that if we do vaccination, we'll do it each one with a separate needle. So, however, if we're back against the wall and we've got vaccine and we don't have enough needles, I'm going to be out there boiling needles, I'll tell you that.
On a sort of related note, do you think that in today's political current and views about public health, do you think that this same campaign could have been done again in 2010, 2011?
You're basically saying, suppose we started with smallpox eradication today, could we do it?
Yeah.
You know, I've thought a lot about it. And I'm not sure I know, to tell you the truth. I think it would be vastly easier because of communication. And you got cell phones and you've got internet, my goodness, that what you could do in the communication is marvelous. On the other hand, I think there's certainly more in the way of large-scale civil disorder than I think we were seeing, although we did see quite a bit during the smallpox program. It's a bit different. And I really just don't know. It's right now, the bureaucracy is much more elaborate than it used to be. And it's very hard to cut through red tape, much harder than it was when we were out there and working on it. So it gets more complicated getting from here to there, which makes a lot of decisions more difficult than we had. So I really don't know. I would only say this, that 2001 came, and I was brought back into working in Washington, and we had at the time we looked at it, there was intelligence which suggested that there could be a second event, and it would be biological. And we assumed for other reasons it would be smallpox or anthrax. And we checked with CDC to say, okay, tomorrow we discover we've got a smallpox outbreak. How much vaccine have we got? At that time, they could put 90,000 doses in the field. Not enough really to do much of anything. In our whole supply, then, as the vaccine, some of the material that had been stored since 1978 came around, and then we came up to 15 million doses. But my goodness, if you had a smallpox outbreak and you want a lot of people vaccinated and a lot of people demanding vaccination, 15 million isn't going very far. We talked with people before 9/11 for other reasons to say how long would it take to produce more vaccine, because by the time vaccination stopped everywhere, and there is no smallpox vaccine producer. We're confronted with that and what to do. So we talked with some of the very key people and said, look, if we need that vaccine and we cut every corner, how long would it take to get us some vaccine? And after much discussion, we finally came up with a figure of 5 years. So I can say there were some very hairy moments back in 2001, which are not really described. However, we got an extraordinary person, former Major General from the military, who joined us, and we were all pretty dumbfounded, because we cut red tape like it has never been cut before. And we were, instead of finishing one study to know what to do with the next one, we were anticipating what would be and starting the next study, and so we're overlapping. And we had in 24 months, we had 200 million doses. And could we have done it? Because at that time, it was urgent. And we could move very quickly, and a lot of people were working very closely together. And it was being produced in Austria, for example. And there were problems with the Department of Commerce about bringing it in without special licensing and a whole lot of things that went with it. So I remember the meeting very well, and I said to the man from Commerce, I said, would it help if my secretary called your secretary? He said, that will not be necessary. It will be done. But that was the sort of lever you had, which I don't know whether you would have that same sort of feeling if we were in a real emergency now. What could we do in stopping smallpox? I almost feel like we probably could stop it, but it would take special measures.
You could form a line. We probably only have time for a couple more questions, but
So over the course of your talk, you mentioned a couple of properties that are specific to the smallpox virus and to infection, like there's the evidence of the vaccine, also obviously evidence of the infection. There's like slower spread than you had expected, and with other infectious diseases, there was a cheap vaccine and vaccination techniques. So given all of these things, would you say that the tactics that you used to stop the spread of smallpox then would work combating certain lethal pathogens that are around today? And if so, why?
I think a very good question, and I think the fact is that we could tell where every case was and could build a ring of vaccination around it and immunity so it wouldn't spread was a real advantage. But I think at this time, you can look to polio, and for every paralytic case, you've probably got 200 infections without symptoms or very minor symptoms. So that it's very hard to know where the polio is. So you have to use some different strategy, and that sort of strategy we had with smallpox, really it worked to a degree with measles in Latin America, but only to a degree. It spread so rapidly that the smallpox was spreading slowly. Measles spreads very rapidly, much more than smallpox does, but it still was very helpful. So in polio, would not work very well. But I think the big problem we have with polio, and I felt it at the beginning, we needed a much more potent vaccine. In polio, you really, in the developing countries, you got to have 6, 8 doses of oral polio vaccine to get a coverage or get a take. And it is not heat stable, so you've got to keep it cold right out to the periphery. And I think, at the time, 1988, when we first got into this, I felt we would not succeed in polio without a better vaccine. And that I was all in favor of pushing very hard to get the vaccine first and then begin the eradication, but it's not what happened.
To what extent do you think that the eradication of smallpox has led to some organizations today or foundations setting the goal of eradicating malaria, even though the diseases are very different? Do you think that those foundations really believe that because we eradicated smallpox, that's a realistic goal for malaria if we had a vaccine?
That is a really difficult question, because indeed malaria has been pronounced the objective, I think, of the Gates Foundation, and they feel that it can be done. And I think then others, I think WHO has endorsed this. The question is when. And the problem is that there is not at this time a malaria vaccine which could be used. There is a malaria vaccine very reported just within the last year that does protect, but it's very difficult to produce it. So there's a lot of money going into producing a vaccine, but there's some other things that have happened. The use of bed nets, of distributing bed nets, has been dramatically effective. In a number of countries, it's dropped death rates by 50%. People maybe are sleeping under the bed nets because they don't want to be bitten by bugs, but it's also preventing spread of malaria. So that makes a big difference. You've got the drugs that you could use to treat malaria, and there are diagnostic methods that are developing so that you could do them much more rapidly, quickly, and give drugs. I think that will help. I think the bed nets will help. And I think insecticide will also help. But when push comes to shove, I think the ultimate test is going to be, do we have a vaccine? And the reason is, if you've got a vaccine, then the you've got the antibodies in the individual. And you can go through a whole area and can make them immune. If you're going to treat all small malaria cases, you've got to have a lot of people out there detecting cases, getting them reported, and so forth. And so the bed nets, it's a compliance issue, and that could be better, but is it going to really do it? Well, mosquitoes are biting outside of the time that you're under the bed net. So I think there are several ways. I think there's a multi-pronged attack, and I think if we get a malaria vaccine, which I hope we can, then I think the malaria eradication is realistic. I think I think that many of the people talk about 30, 40 years may be necessary before we get there. But that's not bad to have the goal out here, because I think what it's saying is, let's look at the strategy of how best to address a disease, and but it's far enough out so we could take time to develop a vaccine. We're not going to do something in a hurry, which is going to be totally inadequate.
I had a question about with the malaria prevention. It seems like within Botswana and other countries, they've been able to eradicate sleeping sickness via canceling out the vector through the tsetse fly. Why is malaria so different? Why do they use bed nets? Why do they use so many other policies when, if they were to go for the vector, that would be the true heart of the eradication?
Well, I think with malaria, the difficulty is trying to get, with any of the vector-borne diseases, is trying to do away with the vector, which is very difficult. And vectors seem to have a capacity to mutate and change and become resistant and become a difficult to escape whatever you're trying to apply. It's also difficult because you've really got vectors multiplying in all sorts of different places and trying to apply this widely, let's say doing something about vectors very widely, is really very difficult and very expensive. Is really one of the problems. So that I think in all cases that the vector control is important, and I think to be pursued. It's a question of how far can you get with it and at what cost. And so much of what we're driven by is costs for developing countries. This is, at the moment, we're looking at the question of a vaccine which costs 50 cents a person. And this is really felt to be breakpoint, that if it's any more than 50 cents per person, you're just not going to be able to either get the donor support for long periods, or they're going to be able to afford it in the country. So it's, there's some very difficult problems here, and here I think some very constructive things are being done in support. Gates and others, NIH, are supporting vaccine production in other countries, many countries. India is doing quite a good job. And Brazil's got a very big operation going. China. And so they're able to turn it out in a number of these countries much less expensively, to look at ways that you could make them more stable, a number of things coming along there, and to figure out how to use fewer doses of vaccine with adjuvants that you can add, or giving it intradermally, another approach, and to figure out ways to give it in a different way. I think one of the exciting pieces is a little patch that you can, micro needles on it, very tiny, and you can apply it, and within 5 minutes the antigen is transferred and produces antibody, which is equivalent to what they're getting when they're given subcutaneously. So that this is beginning. It's only a beginning part, but it's demonstrated proof of principle is there. And now could you produce them rapidly at large scale? And I think there's a couple of laboratories have some ideas on this, and they actually are producing some that look like they're very heat stable. And this would make a big difference if you could just put on a patch, a little something about that big, and as long as it's got about 5 minutes contact, at that point you can throw them away. So these are some devices, and also doing things by mouth. Of course, this would be a big advantage, but that's also been difficult. But at least people are working on them right now, and a lot of this with the developing countries in mind. We can use syringes and needles, but they're expensive when you're getting into big numbers, and better if you can do it another way. But I'm encouraged.